the first speaker will be talking about the postpartum psychosis, the bolt from the blue, Dr. Sundarna.
I'm slightly diverting from the topic from the physical health to the mental health. And, as per WHO definition of health, the mental health is as important as the, physical health. Let me talk about postpartum psychosis. I think the organizer has given a beautiful, the bolt from the blue. So what is postpartum psychosis? Now we consider it as a severe mental illness. So, usually when we talk about mental illness, we divide them into common mental disorders, severe mental disorders. So it comes under severe mental illness which has an onset after the childbirth. As all disorders, it has some, prodrome in the form of, sleep disturbances, mood fluctuations, irritability. Even though we say that there are delusions and hallucinations, sometimes in an acute state it is very difficult to elicit delusions and hallucinations, but from the information provided by the family members, we can able to recognize that she might having delusions and hallucinations. Most of the time, it can take the form of mania, severe depression, or sometimes it can be a mixture of mania and depression, which we call mixed episode. Not only that, many women do present with confusion, perplexity, which is a combination of confusion and anxiety, delirium-like appearance, disorientation, derealization, depersonalization. Sometimes we do see disorganized behavior, like the unusual behaviors like neglecting the child, not feeding the child, and some women do have obsessive thoughts regarding the newborn. So how common these disorders are? It's a rare disorder, maybe in prevalence being 1 to 2 per 1,000 live births in general population. The new onset of postpartum psychosis is around 0.25 to 0.6 per 1,000 live births. This is an incidence, and the childbirth itself is an increased risk for the onset of new psychiatric disorders. A woman never in her life seen mental health professionals can see after the childbirth. The increased risk is almost 23 times compared any period in her lifetime. So is it that only psychiatric manifestations is is it just a psychiatric diagnosis? No, many a times even medical disorders can present as postpartum psychosis, as common as infections, cerebral infections, systemic diseases. Eclampsia can present as psychosis. The commonly we see in our tertiary care center is autoimmune conditions, collagen vascular disease, rheumatoid arthritis, SLE, a lot of those conditions. CVT, that CVT is a neurological condition which can present as postpartum psychosis. The recent the new coming is NMDA encephalitis. Is also can present as postpartum psychosis. Many thyroid disorders, hypothyroidism, hyperthyroidism, thyrotoxicosis, these can present as postpartum psychosis. So why the postpartum psychosis is a psychiatric emergency? So this is a paper which was published in 2008 from our own center, which was looked at the suicide rates among patients who are suffering from postpartum psychosis. We looked at their how many of them had suicidal ideation, suicidal attempts just prior to the admission. So more than 1/3 had suicidal ideation, and nearly 1 in 5 women has attempted for suicide in the current episode. And we also try to look at what are the predictors which has we found that if they have presence of depressive symptoms, I said in the clinical manifestation there are manic symptoms, there are depressive symptoms, there are mixed symptoms. The presence of depressive symptoms is a predictor for the postpartum suicidal behavior. This is the, this is a slide which I have taken from the different presentation. It's a late maternal death in UK. No? So where they have controlled, the infections are well controlled over there. Here it's the third most common cause, no? Around 15% of the women. So other reasons why it is a psychiatric emergency is the infanticidal ideas and infanticidal behavior. This is again, the literature from our own center, where more than half of the women, they had infanticidal ideas when they were having postpartum psychosis episodes. So, and nearly 1/3 has attempted for infanticidal behavior, and both infanticidal ideas and infanticidal behavior in combination was seen in more than 1/3 of the women. So there is a significant amount of women who suffer from postpartum psychosis can attempt suicide as well as infanticide. So this is the recent data, it's not published one. So we looked at 85 mother-infant dyad, and what are the risks we can see in these mothers, like suicidal risk in current episode more than 50%, suicidal attempt, nearly 1/3 of the women, ideas of infant harm 1/4, physical harm to the infant more than 1/4, physical violence nearly half, refusal to breastfeed nearly half, infant health problem requiring acute, like when the mothers are suffering, infant require the medical care in nearly 16%, and combination of these is almost like in nearly 50% of the women. So who are these people who are at risk to develop postpartum psychosis? So the primi gravida itself is the most consistent risk factor. Then the history of bipolar illness in the past. If there is a past history of postpartum psychosis and family history, family history of psychosis, bipolar disorder, even substance use. So can we predict postpartum psychosis? Say, as I told, what are the risk factors? Depending on the risk factors, like women with bipolar disorder had an overall relapse risk of 37%. With history of postpartum psychosis in the past, the relapse risk in subsequent postpartum is around 31%. If women had bipolar and she had another relapse in the postpartum, then 1 in 2 women definitely will have an episode during their postpartum period. So can we prevent postpartum psychosis? So when we talk about prevention, either we can prevent during pregnancy or during postpartum, like in the last presentation, regarding anti-epileptic, many women, the compliance is poor for any medical treatment. So when we provide them prophylactic pharmacological therapy during pregnancy, the relapse is around 33% when compared to medication free who do not agree to continue their medication, where it is around 66%. Where if immediately postpartum you start prophylactic treatment, then the relapse rate can come down to 29% compared to medication free around 65%. So how do you manage postpartum psychosis? As I told, it is a psychiatric emergency. We provide them inpatient care. So before we admit, we always try to rule out any primary medical disorder, and we do a thorough risk assessment. I told there is an increased risk of self-harm, suicide, and the neglect of the child, infant harm. So the risk assessment, I am going to show you how systematically we do in our center. There is we do a joint admission. We consider for joint admission of mother and baby, it is a mandatory as per Mental Health Care Act 2017, which is a newly formed act. And apart from the act part, the dyad admission, mother baby dyad admission provides a kind of satisfaction in the mother, as well as it reduces the time to recovery. There is a faster recovery, and mother is able to bond with the child easily. So pharmacological treatment, we have antipsychotics, both typical as well as atypical antipsychotics, which can be safely given during breastfeeding, antidepressant if there are more of depressive symptoms, mood stabilizer. It has been consistently, research has shown that mood stabilizers like lithium, valproate can effective in postpartum psychosis. If we need a faster recovery, we give them electroconvulsive therapy, which is much more safer than any medication, as well as we tend to use intermittent benzodiazepines. So this is a risk assessment we do: risk to self, risk to the infant, risk to others, and other risk factors. And as well as we also try to look at infant health, because NIMHANS doesn't have any pediatrician, so we tend to admit the cases in where the infant health is, we need not to have any interventions, active interventions to the infant. So when we talk about psychotropics in postpartum, like there is a period where there is a breastfeeding happens. So is it safe? Among the SSRIs, the sertraline and paroxetine are considered to be safe during breastfeeding. Clozapine, we don't frequently use clozapine use in resistant cases, which is contraindicated. Lithium, which is I just told, like if the mother want to breastfeed her child, we don't prefer to start her on lithium. Benzodiazepines we use with some cautions, and lamotrigine, not so frequently, but which is one of the mood stabilizer, tend to come in high concentration. And carbamazepine also found in breast milk, significant level, but not the valproate. So even though it is contraindicated during pregnancy, but during breastfeeding, valproate considered to be much more safer. So any specific precautions we need to take? Earlier, they used to talk about the peak levels, and after some time, like after the medication, mother should not feed the child. But currently there is no evidences that once the mother is on medication, after 4 half-lives it has to reach steady state plasma concentration. There is no point in avoiding breastfeeding. So it is important to monitor the infant for adverse effects. Commonly the sedation and feeding part, but we also look at other adverse effects. But the great caution should be exercised when breastfeeding the premature child or sick infant, and mother is taking more than one drug. So if you are in doubt, you can use the LACMED app, which is from NIH. They update regularly this app. You can put any drug, including your drugs here. I would like to conclude my presentation here, and I would like to invite you to our Marseille Society. It is a perinatal mental health society which is conducting the biennial scientific meeting in 2018, first time in India, in Bengaluru, NIMHANS. Thank you.
Thank you very much for your